So I'm going to go ahead and call us to order. I'm Peter Schwartz. I'm the director for the IU Center for Bioethics, and I'm pleased to be introducing Dr. Katleen Gabriels, who's an assistant professor in the research group of philosophy and ethics at the Department of Industrial Engineering and Innovation Sciences at Eindhoven University of Technology. Her background, her doctorate is in philosophy and moral sciences, as well as some other degrees she has. And she studies the ethics related to other tracking technologies. So this would be things like mobile and wearable computing. Of course, in the situation we know that people can track each other. So parents can track children. In our offline conversation going on here before the talk started, universities can track their students. My favorite Dilbert cartoon, one of my favorites, the boss refers to his cell phone as the employee tracking device and asks him why it is not on. I'll have to give you that cartoon for your future lectures. And so she looks at these issues as well as, and I just had to copy these down as incredible buzzword, hot topics in moral philosophy, Internet of Things ethics, the Internet of Things, and the ethics in virtual worlds. Both very interesting and cutting-edge issues, and we're very pleased to have her. Dr. Gabriels is visiting Purdue for the week and was kind enough to come down to Indianapolis to lecture to us on the topic of exploring entertainment medicine and the professionalization of self-care, an interview study among doctors on the potential effects of digital self-tracking. And so over to you.
Thank you. Thank you for the invitation. So how much time do I leave for Q&A?
We should have talked about this before, I guess. Yeah, maybe I could have told you. Yeah, no, so it's an hour session. We always like to end with 20 minutes to go, if possible.
Okay, yeah, that's okay.
If you can't, you can't. But I'm sure we'll have questions here in the room. We also have people participating on the phone, so zooming in, we call it here. It's a telecommunication way. And so they can ask questions too, and I'll try to handle the technological snafus that are inevitable.
Okay. So my talk will be on a paper that I published earlier this year together with a PhD student. So you might have received the text. I don't know if it was also sent along with the invitation. So I will tell more about this study, and then I will also talk about a follow-up study, which is still in its early phase. So this is the outline of my talk. So I will first contextualize the Internet and self-tracking technologies. I guess everyone is familiar here with Internet of Things.
I don't think you can assume that.
Okay, I will give a number of examples of medical instruments that are becoming connected to the Internet. So basically the idea behind IoT or the Internet of Things is that we're not only going online with our smartphone or tablet, but if you buy a new car, for instance, a lot of the dashboard technology is already connected to the Internet. Or to stay in the medical field, if you have a pacemaker implanted, it can also be connected to the Internet, and the doctor can telemonitor you at a distance. So I will talk more about this study. Its findings, and based on these findings, we are preparing this conceptual follow-up study on the notion of the patient manager. Is that a notion that is being used here as well, the patient manager?
I've heard it, but I don't think widely.
So, especially with the wider dispersal of the mobile phone and mobile internet, there's an increasing number of health apps. myhealthapps.net is one of these websites that collects a lot of applications that you can download in order, for instance, to track your how many calories you burn, or your heartbeat, etc. So there's a lot of apps on the market, and I also must say, so I'm from Belgium. We are a welfare state with a compulsory health insurance. And sorry that this is in Dutch, I'll explain it. This is a screenshot from a newspaper article earlier this year. because a number of these apps will be reimbursed by the Minister of Health. So basically the idea is a doctor can prescribe you a sleeping pill if you suffer from insomnia, or he or she can also prescribe you an app. And the costs for that app will be reimbursed. So indeed, as was already mentioned in the introduction, I'm focusing on self-tracking, but also on other tracking technologies, because self-tracking is never just self-tracking. There's always other people involved, either peer-to-peer monitoring, because you can share the data with your friends or your partner, or with nurses or doctors, and obviously, but that's another theme, with a company. So these data are not just being collected by the individual. And basically with these self-tracking technologies, you can attain more transparency about yourself and your bodily data, but you also can see the other through technology. For instance, when data are being shared, or for instance, when a doctor has a look into your data. Philips, the company that was founded in Eindhoven, and I also work at Eindhoven University of Technology, actually has become a health company. So they're not so much focusing on light anymore. So a lot of their work is now focusing on health applications, and for instance, medical instruments connected to the internet. So for instance, when you're suffering from a heart disease, the blood pressure that you're using, you just have to use it every day, but you don't have to do anything apart from that. So the data are immediately sent to the hospital because it's internet connected. Same with bathroom scales, they're also internet connected. So as a heart patient, you just have to step on the scales, and that's all you have to do. You don't have to write it down anymore. It will just be sent immediately. When there is a deviation in the data, it's the same with the implanted pacemaker, for instance, then the hospital will call you. Obviously, self-tracking technologies are not new. So we don't have to see this as something completely new on the market. For instance, when I've seen that this is a center specialized in diabetes. So the glucose meter, for instance, is also a self-tracking technology.
The partner of we share space with the center that focuses on diabetes.
Okay.
We are the Center for Bioethics, but they are our friends and they share our stuff.
Yeah, it wasn't immediately clear from the door. Yeah. But for instance, you could also say bathroom scales is also a way to track your health. So there's this, it's like a continuum. So why this study? It's a very small scale qualitative study. So first of all, there's a lot of publications on self-tracking technologies in healthcare, and either they're extremely positive, or either they're very negative, or either they're in a test bed setting. So it's still an experimental setting. So we were curious about to what extent medical doctors today are being confronted with patients sharing their data with them. So with all these apps and devices, are these data shared with a medical doctor? Obviously, it will eventually lead to shifts in professional healthcare as well. So right now it's still very limited. But you can use self-tracking technologies either for therapeutic use, but also for preventive use. Exactly because it's not so new, we made a distinction between classic self-tracking and digital self-tracking. So what are the main differences? Classic self-tracking, basically the MD, the medical doctor, asks the patient to track, for instance, because he or she is suffering from diabetes. And the data are not shared except with the doctor or the medical team. That's classic self-tracking. Obviously, with digital self-tracking, there is much more empowerment from the patient, who does not necessarily have to be a patient. Also, healthy people can track themselves, for instance, when they go jogging. The distinction also, so the data are shared with digital self-tracking. So for instance, there's also this whole quantified self movement where you can share your data, or you can share them with your partner or on social media, so it's much broader. And here the initiative to self-track comes from the individual. So our national symbol in Belgium is a peeing guy, Manneke Pis. And I must say, sorry I have to interrupt for 30 seconds, but I brought Belgian chocolates for the meeting.
You can interrupt for that.
So I'll just start here.
We're so sorry to everyone conferencing in.
It's right. We will hold up the picture of the chocolates for those of you who are, and there's still time to get here, by the way. The talk will go on.
And there's a lot of chocolates.
She did bring a lot of chocolates.
So, like I said, we are an active welfare state with a lot of social security.
The diabetes tracking you were talking about.
Compulsory health insurance. So either you pay directly, either the money is being reimbursed by the insurance company, or even in a number of cases you don't have to pay because the insurance company pays directly. At this moment, there is still need for a complete reimbursement framework for apps and self-tracking technologies. So there's a number of apps that will be reimbursed. But one of the problems is, and this is also something that clearly shows in the data, is that the clinical market and the commercial market are intertwined. So it's really difficult to know which technologies are reliable and which are not. Sample overview. So we started with a convenience sample, so with interviewing general practitioners that we knew were also experienced with these new self-tracking technologies. And we actually found out that these digital self-tracking technologies were not a part of everyday healthcare yet. And that's why we also decided to, you can keep on,
keep it going around,
put them in the middle of the table. So that's the reason why we also included cardiologists, because they're also they have much more experience, for instance, with apps that measure heart rates, for instance. And we didn't just pick cardiologists; we picked those who are also related to universities, for instance, and who are also involved with, among other things, the creation of these apps and technologies. So it's not a random sample. It's a sample that only contains people who are expert in this matter. So we had an interview guide, and we first started with the classic self-tracking questions, like how often do you encounter this? Who takes the initiative to track? What about the choice and quality of the device, etc. And then in the second part, we ask the same questions, but then focusing on classic on digital self-tracking. And we also ask them to talk about the differences between classic and digital self-tracking, and data sharing and ethical concerns or expectations related to it. And it was all in-depth interviews. More on the methodology you can find in the paper. So we had a lot of, even though we only had 12 interviews, we had a lot of data, also because some interviews were quite long, and also because they were very much expert on this matter. So In our body of data, there's actually 4 major themes coming to the fore. The patient as health manager, health obsession, information management, and the shifting role of the doctor. I guess you might be familiar with the notion of doctors becoming coaches. The doctor coach is also a notion that gains more importance. So first of all, the patient as health manager, and this will also be the focus of the follow-up study. So basically it means that patients are offered much more possibilities to control and self-manage their health. This does not have to be negative per se, because it's also related to patient empowerment. On the other hand, our sample is very nuanced. So they clearly see the opportunities, especially already with classic forms of self-tracking. But, and this is a very important distinction that they keep on making, it's not for every type of patients. Like, it's not one size fits all. There's a whole typology of patients. So they would not recommend it to just any patient. Also, concerning digital self-tracking, the dropout rates are still very high. And this is also in accordance with other studies, that most studies struggle with long-term effects of these self-tracking technologies, and they face high dropout rates. We also refer to other studies in our paper, for instance, related to patient empowerment. This was a study conducted in Belgium, also a qualitative one. It was in an experimental setting where patients were given much more tools, self-tracking tools, and they found that the patients still wanted to obviously have dialogues with the doctor, and the doctor or the medical doctor as an expert was very much valued, because if there's so much data, you really need someone who can interpret all these data. This idea of the patient manager also goes broader. So this is a startup company in Belgium where you can analyze all your bodily data, and then it's like a chatbot, and it will give you medical advice based on these analysis. And it's in Dutch, but it says word beheerder van je eigen lichaam, which means become the manager of your own body. So it's always about this management idea. And our Federal Minister of Health, Magie de Blok, she also talks about the idea of the patient manager, but she actually calls them co-pilots. So you should become the co-pilot of your own health. So you're sitting in the cockpit together with your doctor, but you're also steering the plane. Second major theme in our body of data is health obsession. So right now, and especially with the cardiologists, concerning digital self-tracking, they don't really get a lot of questions. But if they receive questions, it's mostly by healthy, highly educated people who use it when they're going for sports. And this is also where the sub-theme entertainment medicine comes from, because one of the cardiologists in our sample called it this way, that these data are very interesting for wellness, but they're not medically relevant. And some cardiologists were also a bit like frustrated because people, and this is also a third theme, came with bad devices that just had unreliable measurements. They came to the cardiologists and it was just bad technology. So there is this concern towards an overly focused use of digital self-tracking by healthy people. So this also relates to the broader medicalization trend in society. On the other hand, they're not always negative, so they're very nuanced, because they also acknowledge that you need a group of early adopters that pave the way for the rest of the people. And actually there's some interesting research on health obsession. This is not part of the paper, and it really needs much more research, but apparently there's new conditions because of self-tracking technologies. There was a very interesting paper, but once again we have to be careful with all these results in this stage. But they talk about orthosomnia. So people who self-track themselves, they also have a detailed insight into their sleeping behavior. And so they become so obsessed by attaining the perfect amount of sleep that they actually suffer from insomnia. And it's a very interesting paper that was published this year. You have also orthorexia is another term, that becoming so obsessed with healthy food that it becomes unhealthy. So this health obsession has a, well, it links to broader themes. And then information management, and here there's the distinction between classic and digital self-tracking is important, because concerning classic self-tracking technologies, there's already a reliable list of brands and labels that you can use, for instance, concerning glucose meters. But at this moment, there is no reliable list of apps and wearables. And actually, there is some research on these wearables. And if you would use 2 different brands on your body, the chances are quite likely that you will get different data. So they're not always very reliable. So this relates to this theme relates to data production, data analysis, also interpretation methods. Quality and reliability is an important sub-theme, and also, and this is really interesting, I think, the importance of context, because these data are always generated in a context, and it's very new, obviously, so we're still at the beginning of all these digital self-tracking technologies. But one of the cardiologists is involved with research, and and this is it's an anecdote, but it's a very interesting one. So he telemonitors informants in one of these studies, and he gets a notification that one of his informants / patients has a deviated heart rate measurement, and it's 11 in the evening on a Saturday night. So he sends this patient an email, and then this patient replies like, "Oh no, nothing wrong. Well, it's actually not a patient, because it was a healthy person who was also trying the app. And then suddenly there is this deviation in the heart rate, but apparently this informant was at a reception where he met someone during a talk who said, "I'm suffering from a heart rhythm disorder," and he subsequently gave his smartphone to try this technology, and obviously the technology doesn't know who is being tracked. So in order to make this reliable, you need to have a lot of contextual information, which is not always very easy, especially not because of privacy reasons in a number of cases. Obviously, this is it's an anecdote, but it's still an interesting example of how important context is. And if you would make any therapeutic decisions based on that context, it's obviously you don't want that. On the other hand, it's not so easy to attain all this contextual information. And then a fourth theme, the shifting role of the doctor. So the doctor is more and more becoming a coach. And yeah, also here, mixed feelings. For instance, data overload. Obviously, a doctor is not 24/7 online. So you need reliable thresholds because you cannot consult all these data all the time. And this is also an interesting quote that relates to responsibility. So a GPU says that if I receive this data, I am responsible. Whereas if I never receive the data, I cannot be held responsible. So how is this data be sent to the doctor, for instance? And what about responsibilities? And again, a cardiologist, also a very interesting quote, that there is a lot, that at the moment, he says that these patients who are tracking themselves, because they are generally just healthy people, they lead to an overload of medical consumption, which is unnecessary. And obviously, the more health information, the better. However, the more crappy data you can leave out, the better. But there's also a focus on positive aspects. For instance, with chronic patients, if you have all these data and graphs beforehand, you just have a quick overview. Because right now, the situation is, especially with elderly people, that there's written notes by a nursing team and the doctor just doesn't have an overview. And so it could save time, and this time, in ideal circumstances, could be used for more in-depth conversation. So a very important context dependency of healthcare. It's not just for any patient, and also obviously these measurements always take place in a context. So you always need to have a broader overview. Some concluding remarks about this is that obviously there is a very important distinction between active and passive tracking. There is no dropout rate with an implanted pacemaker, for instance, because there's no active part required by the patient. But from the moment you ask someone to self-track blood pressure or to self-track bodily weight, you will always face a dropout rate. So how are you going to overcome that? And there's some of the cardiologists talked about, for instance, when you're just brushing your teeth in the bathroom, there could be like scales on the floor, and this data is immediately sent to the hospital, so people don't really have to do something in order to prevent dropout rates. The distinction between wellness and medical necessity, also the distinction between the clinical market and the commercial market, which is still very much intertwined, and also a policy vacuum. So right now, most of these technologies are still unreliable. So at this moment, we're working on a follow-up study because we kind of became intrigued by this notion of the patient manager. And I want to, well, it's still in its early stage, so, but I think it's interesting to share our thoughts on this, and I'm very happy to receive feedback and criticism. So I already gave the example of our Minister of Health and also of this company talking about the patient manager, but here Eric Tophall, who is an American cardiologist, but he's also a professor. He wrote a number of books on this, amongst others, The Patient Will See You Now. And he also talks about digitally empowered patients who will truly take charge of their own healthcare. Also, this new notion of positive health. I don't know if you're familiar with that. So right now, health is also being conceptualized as the ability to self-manage in the face of social, physical, and emotional challenges. And actually also in a non-clinical context, if people are self-tracking, there's a recent study, obviously also with a very small sample, so we have to be very careful. We cannot make any generalizations here. But it's a recent study, amongst others, conducted by Deborah Lupton, an Australian professor who is doing a lot of research on self-tracking. And also the findings reveal a lot of focus on self-improvement in terms of health, finances, and work productivity. And they want to take responsibility for managing their bodies and lives. So it's a discourse in terms of management, productivity, and efficiency. So in our new paper, we want to critically look at the ultimate goal of the empowered patient as a health manager, because our concern is that basically the idea of the health manager is driven by cost efficiency and not necessarily driven by an ethical drive. Because obviously you would reduce a lot of costs if patients would self-track. And we are analyzing a number of important concepts such as patient empowerment, autonomy, etc. So the notion of patient manager, it's actually quite clashing, because on the one hand you have the patient, who is being defined generally as a receiver of care, and on the other hand you have the manager, who is whose job is to control, and I'm referring to the Cambridge Dictionary here, whose job is to control and organize someone or something, especially a business, and it's very often about predefined goals. So this whole idea of the patient manager is clashing to a certain extent. Obviously, we don't want to criticize the idea that people are responsible for their health, obviously. You have to eat healthy, exercise a lot, but health is not just something individual, it's also a societal issue. So there's this whole discourse about cost efficiency. So in order to beat, I don't know if you're familiar with the notion silver tsunami, because we have an aging population, we will also have an increase in chronic disease, therefore healthcare will become affordable. And it seems, especially in Belgium and the policymakers, etc., they propose the patient manager as a solution. So you have to become the co-pilot. Obviously, there's a crucial role here for technology, and this is something that we also want to explore, because they talk about autonomy, but there's actually a shift of dependency, not from the doctor, but dependency of technology. So there's, on the one hand, you have autonomy, which is the opposite of paternalism, and we're also not pleading for a paternalistic approach in healthcare. We want to be very clear about that. And actually, full autonomy is really, really hard to reach, because in general, our decisions are heteronomous, in the sense that when we take a decision, not only in a healthcare context, we very often ask for advice, and then we take a decision. So it's not completely autonomous. The notion of patient empowerment is also proposed since a number of years to go against this whole idea of paternalism. But what is important here is that the patient is empowered and is given a lot of opportunities to choose, but it's still taking place in a web of relations. So there still is patient support, and there's attention, ideally, for information and education. It's not about just organizing your own care, because it's too overwhelming. So we have to really see this patient empowerment in a relationship between the nursing team, the medical doctors, and the patient. There is this web of relations. I wanted to show a video, but I'm not going to do it because I'm running out of time. It's about assisted living. So basically that your house is being, well, there's a lot of sensors in your home. And when, for instance, when you don't take your medication, you are alerted, and your family members, they also receive information in the form of emoticons. So for instance, an unhappy emoticon means that mother or father didn't take medication.
Your family just got unhappy when we ate our chocolate. Your children have been informed that you ate a piece of chocolate.
But on the other hand, your happiness must have increased by eating Belgian chocolate.
Yeah, I'm against the emoticon. I'm pro the chocolate.
Yeah.
So basically, we want to critically analyze the notion of the patient manager. Because how autonomous are you when there are so many sensors? So you might not be so dependent of a healthcare system anymore, but there's obviously the technology, which is also part of the healthcare system. And there's also a lot of nudging involved. And it clashes with this whole idea of empowerment, where you're still being educated. So it's not just independent living, it's technology dependent living. And once again, we're not totally against it, but we just want to be critical about this notion that seems to pop up increasingly, the patient manager. And we also refer to an interesting framework by a Dutch philosopher who makes a distinction between logic of choice and logic of care. So basically, logic of care means that you're still being treated as a patient, that the fact that you got a disease was not your choice. You can also become ill because because of bad luck. And she makes this distinction with logic of choice, which basically means that you're more and more being treated as a customer. So you as a patient get the choice, but you have to choose well. And so it's her criticism on this. Well, I'm going back to the other slide. So basically, in the logic of choice, you are making the decisions, and it's your responsibility. So there's a lot of focus on the patient, and to a certain extent that's good, because it also relates to empowerment. But obviously, we must not lose sight of this whole web of relations, which gets more attention within logic of care. And I'm going to the final slide, because I also want to have some time for discussion. So once more, it's still in its early stages, but on the one hand, you have this notion of the patient manager, which seems to be echoed in this logic of choice. And this whole idea of self-tracking is also presented as a means to reduce costs related to the Great Tsunami. We're quite critical about the notion of autonomy here, because there still is a dependency, the dependency on the technology. And the position of the care provider is not really clear here. Whereas, for instance, with the patient empowerment, there is still an outspoken role for the doctor coach. There is also, obviously, healthcare is very dependent on technology, but you cannot just impose it on people. You always have to inform them about the whole context. So basically, to wrap up, perhaps the ultimate question is not how can the patient be independent, but from what does the patient want to be dependent? Is it the doctor as a coach, as an expert, or is it the technology? And I realize we're still treating this in a very black and white way, but I'm very curious to hear your suggestions and feedback. Thank you for listening.
Just before we get started with the Q&A, Dan and Howard, if you have any questions you want to submit, if you just scroll over the presentation, you'll see a chat feature towards the bottom, and you can submit your question there, or if you just say, I have a question there, I will unmute you and you can go ahead and ask. If that doesn't work, feel free to unmute yourself, but I figured that this way there might be a little bit more order to it.
Thank you, Tom. Excellent. That's a good plan. We don't know how to do this yet. This is our technology we're dependent on. So. Okay, so questions or thoughts?
I want
TJ.
I want to ask about, so this last slide in relation to the first study you did. It sounded like, so doctors were involved with it, even if they were healthy patients, getting alerts at like 11 o'clock on a Saturday night or whatever.
In a research context. That was in a research context.
So currently, though, is the current system very paternalistic, where doctors are always monitoring these things and getting very heavily involved, even if someone's completely healthy?
Well, no. So basically, so you have to make a distinction between the classic form of self-tracking and the digital form of self-tracking. So in general, doctors don't get a lot of questions about digital self-tracking, but if they have questions, it's generally from healthy people. So it's not yet a standard part of professional healthcare. But there's this whole telemonitoring thing. So for cardiologists, for people who have an implanted defibrillator or a pacemaker, and there is also you can find that in the paper. So there's also some criticism on that because the doctors become overloaded. So there's this the data go to a team of nurses. And only in a second phase, the doctor or the cardiologist is involved. And the notification on a Saturday evening was in a research context, yes. And this was a healthy patient who gave the technology to a heart patient.
So would you say, though, that the current system then is not very paternalistic? There's nobody really getting heavily involved when a patient comes to the provider and says, I want to start tracking my heart rate. Do the physicians really jump in and start managing, or are they still very hands-off?
I can't make any general claims about that. I know about, for instance, there was one anecdote from a cardiologist where someone was worried about his heart rate, and then the doctor obviously had to do a checkup, and it turned out the technology was bad. So that's why he was so critical about it. At this moment, their concern, or during the time of our study, the concern was more about if they all come here with these data, we have no context. We have no way to deal with it.
Questions? Otherwise?
Yeah.
Right.
So the worry about sort of anxiety at sort of being faced with too much data of your own, is there an imaginable world in which that's solved? I mean, what would that look like? So the difference between the logic of choice and the logic of care, how does that anxiety fit into the logic of care?
Which anxiety do you mean?
Sorry, over the anxiety that's induced by tracking your own data continuously.
Yeah, but that's still very marginal, I think.
It's marginal.
Yeah,
Okay.
yeah, it's still very marginal. Because I have to be very clear about it. The digital self-tracking is still so new, and there was only one paper on orthosomnia, so I don't want to make it bigger than it is, but I thought it was interesting because it is used as a health technology, but you also get some revenge effects there.
Can I ask a question? So about the policy issues here, you said in Belgium they're actually paying for these. And I wondered about this whole idea of, I think all health systems around the world face cost constraint, cost challenges here, maybe more than anywhere. And so the fact that people are being paid to use apps that even these early adopters among physicians you spoke to are pointing out some obvious limitations. One, in their potential clinical use for individuals, and two, their potentially regressive effect on public health. Right, the healthiest people who are already jogging and watching their weight are now sending reams of data to their doctors. I would wonder, like, where's the evaluation there, and where's the sort of thing of saying no, we're not going to spend money on this. We're actually going to spend money on, addressing the obesity epidemic or addressing the opiate epidemic, instead of addressing the worried well getting a entertainment medicine. Where's that?
They're reimbursed in the sense that if you're worried about the data from bad technology and you're going to a cardiologist for that reason, you will always be reimbursed the money. So even there is no quality distinction, like, okay, you came to a doctor because you're a hypochondriac, no, we're not going to reimburse the money. So you will always have the money reimbursed. But on the other hand,
oh, good.
That's the system in Belgium.
Here too.
But the apps that are currently being reimbursed, that's a very, very limited number. And these apps are only reimbursed if the doctor has prescribed them.
But that's not much of a limit, right? Doctors do all kinds of things that patients ask for them. They say, Doc, I want to track my heart rate when I'm running.
No. But it's only like a few apps that are already being reimbursed. And obviously, indeed, I don't know if a healthy patient comes and says, I also want to use it. I have I cannot look into the doctor's cabinet there, so I don't know. So, but what is your concern there?
Oh, well, my concern is even in the case of a patient with a condition, say, here's an example. So I have a patient who's seen in the emergency room for it's actually a true story. But she was seen for some irregular heart rate, and the electrophysiology team saw her and said, yeah, she's fine. Let's just put her on a 30-day cardiac evaluator. Now, that now is in place. There's a tremendous amount of expense to that. There are alerts that get sent to a call center that call me. And I'm not even complaining about the calls, which are ridiculous, but that's not really the problem. There's a tremendous expense being spent on a technology which I don't think there's any evidence for this in her situation, much less probably any situation. She has a real condition. It sounded like a good idea to the doc, like, oh, let's just evaluate her heart rate for 30 days. But that's another case of American medicine, as an example, sort of bloating into a new technology that sounds good, which gives you information, but no hardcore evidence for benefit or cost effectiveness. That's exactly how the system bloats and crashes. And so when you just mentioned in your setting of apps being paid for, I understand probably in the setting of conditions, is anybody calling for evidence-based medicine here and saying, hold it, wait until you see benefit? Because that would maybe address some of your doctor's concerns also of no, just settings which we will agree to receive information and pay for the app only if we have evidence of improved outcomes from doing this kind of monitoring.
It's a very good point, because that Tanya, my co-author, and I had shared the criticism because a number of apps are being reimbursed, but these apps, so they were also they were designed by research teams also, so it was a private-public, very often a private-public combination, so a company working together with researchers, but they were only tested for, I don't know, like 12 weeks, not even 6 months, so it's a very, very short time frame. So from a research perspective, that's just not long enough. And then obviously from a policy framework, it looked interesting, because the hope is that in the long run they will reduce costs. So indeed, we don't have any reliable long-term data, and this is also something we discuss in the paper, because the patient manager is not a separate paper yet. It's also something we discuss. Wait, I'm losing. We discuss a number of studies, long-term studies that involve self-tracking, and actually the results are quite meager there. Even when it involves, for instance, weight loss, I think, I'm not really sure, so don't
no, that's
take
right.
me
The
personal,
data's very poor.
But actually, weight gain in the end. And basically, and I didn't talk about it, but a very important distinction here is between intrinsic and extrinsic motivation. If you're not intrinsically motivated to lose weight, a self-tracker will not help in the end. And the dropout rates are really high. Like most people stop after 3 to 6 months. So we don't have a lot of long-term reliable data. And I think it's a good point that we're focusing now on professional medication, and we're already prescribing some of these apps in Belgium, but we don't really know the long-term benefit of it. On the other hand, Belgium is also a country where so much medication is being taken, so maybe it's better to have an app instead of all this medication.
You're going to waste your money, waste it on apps. Okay. Good.
Yeah.
Questions, thoughts?
Is there a possibility that the app tracking could help someone with illness such as alcoholism, or maybe someone who's addicted to smoking?
The ones that are being reimbursed right now in Belgium, you mean? Or in general?
In general.
Well, I think the ones that are being reimbursed right now, there's none of these, I'm pretty sure. So it's about diabetes, heart rhythms, also for revalidation, is that a word? No.
Revitalization?
So when, for instance, you had an accident and you need some physiotherapy.
Rehabilitation.
Yeah, rehabilitation. I'm pretty sure that there must be apps out. Well, I know that there's a plethora of apps to help you quit smoking. And I'm also sure that a number of them have been developed in a research context, but I don't know anything about data findings. And alcoholism, interesting, because I think it could be helpful. Well, I'm just thinking about it because it's much less in your face when you have an app, I guess. So that could help you. But I have no examples of that. I know that the cigarette apps are very popular, and I have friends who use them because they also calculate how much money, for instance, you've saved on a daily basis. But here as well, the distinction between intrinsic and extrinsic is important. And we're talking about addiction with cigarettes, so yeah. So they're out there, but I cannot make any statements about their effects or reliability.
More questions?
I wanted to ask about data protection stuff. So I think in the US, when people are worried about patient manager stuff, a lot of times it's because nobody really knows who owns the data. So if I've downloaded stuff on my phone and it's somehow connected to an app and my provider gets information, so does a million other people. Or we don't even know who's all getting it. And the reason that having the healthcare provider more involved is that they could also be involved then in protecting the data. Is that a concern, I guess, that comes up?
Very much.
Okay. And
Yeah.
how's it addressed?
Yeah, so it's part of the information management and safety, and some of you must also do research, I guess, on electronic health records here, because it's a similar concern. Like, how are you going to protect all these data? And there have been hospitals hacked, also in the US. So what I also must say is concerning these commercial self-tracking technologies and apps, there is an enormous distinction between Europe and the US, because in the US medical data can be sold. In Europe, this is not allowed, but for instance, in Europe, if you download an American app, you're already in a gray zone. Now we have stricter stricter rules on privacy in Europe. So I guess if an American company would do that, they could be sanctioned from it. So data protection, this was a theme very much. And this is also the reason why our Minister of Health asked research teams to design the apps and not just take any app that's on the market. On the other hand, we're dealing with computer technology. It's never 100% safe from hacking or anything. I guess the concerns are similar to the EHR, so I don't really have a one-sided answer on that. It's if the app is reimbursed, it must meet a number of strict rules that I know, but it's true that people are very naive about downloading just any app on the internet, especially when bodily data are involved. And I know that in Europe there's a number of concerns because of these American companies, but I don't really have an answer to that. Yes?
I'm curious about this interplay between autonomy and understanding.
Mm-hmm.
You've done some work on how patients understand risk. This
Interesting.
idea of medical information and how that influences patient. You know, if they're getting and tracking their own information, they want to have the freedom to be able to do that. But if we know that there might be potential harm because they don't understand what it is, how do you balance between patient education, patient understanding, and autonomy? I'm not suggesting that we create another class of protected people with restricted autonomy for various reasons of some sort, but how do we balance those two?
It's a very good remark, and this is also the reason why the self-tracking, both classic and digital, is always context dependent. So that was in our sample a constant. I would not do this with just any patient. So you cannot say that doctors are never paternalistic, because you could see this as something paternalistic. But on the other hand, if you have, for instance, is it hypochondria? Someone suffering from hypochondria. There's two ways. So on the one hand, the data might make this person more relaxed, but on the other hand, it might go the other way. So that was a theme that was like constantly returning, because it also not only relates to hypochondria, but also to literacy. Not everyone is capable of this, and this is also something that we talk about in the paper, self-diagnosis. This is something that is already happening all the time with classic self-tracking. So for instance, with diabetes, patients interpreting the data and adjusting their insulin based on their own interpretation. And mostly this is going okay, but there's always examples where it's going wrong. And this is also a concern, self-diagnosis, because there's so much data, and people who are using this technology are not the ones who are educated to interpret all these data. There's a reason why doctors have to study for so many years. You cannot just expect that any patient will interpret these data. And this is actually also a criticism on the works of Eric Topol, because he seems to take into account just the ideal patient, the patient who understands everything perfectly, who will never try self-diagnosis. He's extremely positive about it, whereas when we talked to the doctors, it was always this context for this patient, yes, not for this patient. So we had, in the end, a whole typology of different patients.
Okay, yeah, okay, that helps me understand.
Yeah.
Thank you.
Thank you so much.
Thank you.
Thank you so much for coming.
Yeah.
And have some more chocolate.
Yeah, well, right. Thanks.